Hey, gurus. It is great to see you tonight. Thanks for coming out. We've got a fantastic show. I'm Denise Richland. This is my partner in crime, Bill, and we are just excited to see you tonight.
Hey, everybody. Welcome. Thanks for tuning in. I'm going to do a quick little swap here. Put myself on the other side of my beautiful wife here because we have a great guest for us tonight. You guys are going to really enjoy her knowledge base. Her name is Tracy Rodgers. I'm going to bring her on here in just a second. I have known Tracy for, it's been over 15 years now, and she's got quite a story and a testimony to tell. And but we're here mainly to pick her nursing and her wound care brain. So let's bring Tracy Rodgers on with us. Good evening, Tracy. How are you?
Good evening. Great to be here. Nice to see you guys.
Excellent, excellent. Well, we are so glad that you were able to take the time to come and be with our audience tonight. We know you've got a lot of great information. We obviously are billing out your expertise tonight in the legal area because you've got an extensive background in that area. And I know that is always a topic that is a hot issue for wound care clinicians to know and to get to know more about, because obviously every time we're out there, we're always at risk. I believe the top two areas for malpractice lawsuits in healthcare are wounds and falls. I don't know if that's changed much, but I know those are in the top ones out there. So why don't you, before we get started though, just so our audience can get a chance to know you, could you tell us a little bit about your background?
Well, I've been a nurse forever, probably as old as dirt. I got into nursing, was an LPN when I was 18 and RN by the time I was 19. So 30 years of nursing practice predominantly has been with geriatric, long-term care, skilled care. You know, I started out on the younger end doing emergency room, ICU, OB labor and delivery, and over the years really found a love for home health and our geriatric population. And during that time, I found that there was a real niche for wound care where I lived. And so I kind of like transitioned into that area. And that's what I've been predominantly doing for about the past, realistically, about 25 years. Love it. Love everything about wound care. And also during that time, it was back in 2004. I had also gotten my legal nurse consulting. I took a 2-year program through Kaplan College and then went on and actually got board certified as a legal nurse consultant certified. They call it LNCC. Had an opportunity to actually sit on the national certification board for that. And so I'm well versed as a subject matter expert in long-term care, skilled care, geriatric care, and especially wound care, predominantly in wound care. And Bill, you're right. We, in the long-term care setting, assisted living, that type of area, wound care and falls are some of the top litigated areas that we see as far as like nursing home lawsuits. You bet.
Okay, cool. Excellent, excellent, excellent. So with that kind of leading into our topic for tonight, what would you say constitutes a legal or medical malpractice case in the first place?
Well, we know that, first of all, it can't be a casual effect, okay? There has to be a direct cause and related when it comes to setting up a case. So a lot of times, what I hear all the time, you hear from the lay people, they'll say, I'm going to sue them. You know, people think they can sue for anything. We can't in today's climate. Of course, I'm not here to speak as an attorney. I want to put this out there. I'm speaking solely as a legal nurse consultant. So I'm not offering like legal advice per se, but I can speak to the standards care and standards practice and that realm, which is in my legal nurse consulting auspice there. But there has to be a direct patient care relation, right? Like you had to have some direct contact care, however that was, referral, something overseeing the patient. You can't be sued for somebody that you didn't have anything to do with. There has to be a breach in the standard of practice. And so in every state, an expert in whatever area that's being sued for, say for like for where I sit, I do both plaintiff and defense work, would be wound care, long-term care, geriatric, like hitting on the falls, hitting on where the standards of care and standards of practice met. And we always go back to, you talk a lot, Bill, about the litmus test. The one thing that we always fall back on in this end is, did the person who's being named or the facility, did they do what a reasonable and prudent nurse or practitioner, did they do what they would have done under same or similar circumstances? That's the same thing we go back to. We are, depending on what your credentialing is. So if you have a higher level of credentialing, if you're a WCC, DWC, if you're a CWN, whatever that is, then obviously your knowledge base is higher. So you will be held to that knowledge base. And so, but a lot of people think in rural areas, like we live in a very small town. We don't have access to everything. That doesn't excuse not following like certain standards of care and standards of practice. And then lastly, every attorney would tell you on this end, things can happen or go wrong even when everything is done right, right? We know that. But things can happen that we had some participation in that, however that was. We didn't do something, an act of omission or something we should have done, or we did something just blatantly wrong, but there has to be damages, because damages is where the monetary end comes in, right? So even if something was done wrong, if there's no damages on that, or if whatever was done wrong was a quick fix, quick kill, and essentially like no harm, no foul,
right,
that you're going to have a hard time finding an attorney, because it's the money compensation end at the end, right? Ultimately, it comes right down to the money. No matter what anybody says, there always has to be the monetary end on that.
Excellent. I want to just say one quick thing. I know you got a question, darling, but I forgot to mention it. For those of you that are tuning in live, if you have any questions that you wanted specifically ask Tracy tonight, other than legal advice, but if you got anything legal related, please type it into the chat box, into the comment section, and we will make sure that we address those questions. So back to you, Denise.
All right. So Tracy, what kind of things do you see healthcare providers doing that put them at risk for being a defendant in a case?
I think the number one thing, I teach a lot of documentation courses, and I teach it to physicians, nurses, CNAs, PT, it doesn't matter who it is. But the thing where they always get themselves in trouble, it always comes down to documentation, always. Because a lot of times we may have done things right, but if it's not in writing, it's essentially wasn't there. Right. It is, your documentation is the way that you show what you did and that you met the standard of care, and it can never be brushed aside. I know I have had defense attorneys say to me before, well, isn't it true? It could have been done. It just wasn't written. And I always kind of put back out there, like an attorney's job with all their paperwork and all their paper pushing, half their job is paperwork. Half of what we do is documenting what we did, how it was done, the response that it was done. That is as much of our job as what we actually do. And so make sure that, you're always, I always say, just do what you were taught in your school program. They will always teach you right, always take it right back to the basics and document the things that you had done that shows that you met the standard of care. It's not hard. I think we get lazy, we get complacent, we start using playful acronyms and those kind of things that can really set you up to not have documentation that would support that whatever you were doing for that patient met the standard of care, standards of practice. So that's probably the biggest thing that I see. The second biggest fault that I probably see is a failure to follow good standard of practice and standard of care, that we don't get to take liberties or practice outside of our scope and practice. We may have seen things done, we may have had experience, but nurses especially, I'm putting this out there, from a nursing perspective, you need to be well aware of what your state practice act is, what federally, nationally, what you are allowed to do under whatever scope that you're in, because you can go to a class and learn something, but it doesn't necessarily mean that within your state's scope and practice and guidelines that you can do that. And then even more so, the facility or wherever you're working may also have some restrictions of things that you can or cannot do, So I think it's interesting how many practicing healthcare providers in any area, if you would say to them, are you aware that your facility policy and procedures for this said this? And many of them first of all, they don't even know where to find them in their facility. Most times they're online now. But secondly, I think when we get hired, or if you've been there a while, I think they don't value them. They're very underappreciated, and yet it is the thing that you will be held against you. When we start in with a case, one of the first things I will request is, I want policy and procedures if they have any standing wound orders. What are their turning orders? What are their nutritional orders? Like, I start hitting those things straight up, because those policy and procedures sometimes can be a little more stringent than what the standard, like national standard, would be. So an in-house policy and procedure is one of those things that we reference those. And if nurses don't know what their own policy and procedure, that just doesn't look good on by anyone.
Now that makes a lot of sense. So you mentioned documentation, and you mentioned like being aware of your scope of practice, and you mentioned standards of care, things like that. Have you got any other advice on ways that we can protect ourselves?
I am a big fan just of I recommend it all the time. I think every practicing provider should have a insurance policy. I know there's a number of them out there. Some facilities will say, I've been told by nurses that have said, I was told if I had my own like insurance policy, I could be fired. I would dare say that if they're telling you that, you probably don't either want to work there, but secondly, they can't restrict you from having a supplemental policy. I would go back to them and tell them that is not something that they have a right to determine, whether or not you can have a supplemental insurance. The thing is if something did go down, and say, usually, generally speaking, in wound care, it's not just one nurse who's named, right? Or one physical therapist. Like, every nurse that saw that patient for a period of time could be named, or in whatever period of time that the incident happened. So in that instance, you actually have an attorney that's assigned to you, that's there for you, that has your best interests. And then you've got your own, policy limit, because sometimes I have seen where facilities have failed to represent one of their nurses who they said floated to another floor. The nurse did not inform them that they didn't have the training to be on that floor. They accepted the assignment. And I just want to put out there that I'm sure that the nurse felt like, she had to do it. Or if she said, I can't go there, like, there could be issues within the facility. Like, I understand that whole thing. But the truth of the matter is, if they're floating you to a floor, you're working in an area that you don't have the training to be there, or you're putting yourself or your patients at risk, then the facility can step back and say, she had a responsibility to tell us that she wasn't competent to be on that floor, and this happened. We do not have to insure her under our house insurance plan. So you could be left out hanging. The other thing that I always hear, which is funny to me, this comment, I hear it all the time, and they say, well, I've been told, and I kind of was told this early on in nursing, again, like 31 years ago, this was what they told us: if you have an insurance policy, they'll for sure sue you because you have insurance. And I'm like, if you hurt someone's loved one, someone's nana or papa, their mother, father, whoever it is, if you truly wrong them, they turn up dead, I have news for you. They're going to sue you anyway. Right. But it would stop them from, no amount of saying, I don't, because then they, I've actually been on plaintiff ends where they've gone after things like, a nurse had a son that had a college fund, and because she didn't carry and was named, so they went after the son's college fund because there was this stack of money there, right? That because what was done was so egregious, the judge actually said, yep, that money can be up for grabs. I've seen a case where a doctor felt like if he carried insurance, that he wouldn't be sued. They took his home. If you wrong somebody and hurt somebody, it's a harder case to go. But if it's a big case, and you have an attorney that's like really passionate about that, especially if the attorney might be like family related to whatever went on, then not having an insurance policy, at least you can say, I have an insurance policy that has $1 million, cap there. And that, and you've got an attorney to represent you, like solely for you, somebody that's there just for you on your side. You're not being split between all the nurses, and It's somebody who has your best interest. So that's kind of been my experience. Like I said, I'm a big fan of having your own insurance plan. And the thing is they're not expensive, but I will say this, make sure when you're getting that, because my plan where I do expert witness work and wound care consulting, they have add-on addendums that go on like a regular. You have to make sure that your insurance is aware of how you practice, like what your scope and practice is, and that you're insured for that, because nurses will have insurance, but it may not cover them under the auspice that they're working. So just being very open with your insurance carrier, telling them what you do, how you practice, and then of course, as always, practicing within your scope and practice is important.
I got a follow-up question that actually I think pertains really, and it came in from one of our audience. How do we protect ourselves and our license from a facility full of dabblers?
Full of dabblers, meaning?
You know, the term dabbling, where people are not, they're really practicing way outside standards of care, and, you know, they're not practicing good evidence-based care. How do you protect yourself when you know what good care is, and the people, the rest of everybody else doesn't want to practice every good care? How do you protect yourself in that case?
You know, and that I think is going to be a tricky situation. The thing that I would always, you have to kind of think, you always have to protect yourself, because at the end of the day, if you think that if you've done something and you think your, say even ADON or director of nurses is going to be there, because an ADON or director of nurses, like in long-term care, and many of these, they get named 100% of the time, no matter what, right? So if it's like a floor nurse that did something, the ADON, director of nurses, anybody that was notified, the physician, all those people are going to be named, and they're going to be looking out for who? They're going to be looking out for you? Probably not, if it comes right down to it, right? They're looking out for the facility, for themselves. And so if you know that there are issues, those are things that you need to have a constant source of, whether it's like an internal, I reported this to the director of nurses, that this, you know, I knew that this was coming up with this nurse. And I can tell you, there's sometimes maybe a hiccup. I've been exposed to that personally, where if somebody's shutting you down because you're practicing the standard of care and good standards of practice, and they're allowing people to practice outside of that, the only thing I could tell you is it's probably not a place that you really want to work, right? Because then you're really putting yourself on the line as well, because you're going to go down with a sinking ship no matter what. No matter how good of wound care, whatever you did, you're going to probably get drug in with them. And at some point you'll be able to say, but you know, this is what I did, this is how I was. You could be let out at some point, but that doesn't mean that first and foremost, you're going to be named with the rest of them. So always having really good communication in your records about who was notified, whether it was the DON, ADON, if you see issues. We've even been told on a wound care perspective, if I go in and like my dressing is off that should have been on, I put in the notes, I arrived, the patient was on their left side, there was no dressing on their coccyx, you know, like I paint a story, you tell a story. And I always say, you paint it in color. Anybody that knows me, every facility that I've worked at, especially since doing legal nurse consulting, they will say, you write like the most detailed notes. And I said, I could tell you what, if mine ever went before an attorney or whatever, because many times you don't get named until a year or two later. Many states have, Nevada's like a 1 year statute of limitations from the time they knew or should have known there was an incident, right? But many states are 2 years or 3 years. So by the time it actually gets for a deposition or court or trial, you may be 4, 5, 6 years out and seen thousands of patients in between. You may not have a total clear, concise thought about that patient. And so make sure that your notes, no matter what you're putting in, that it really does paint a clear picture about what you did, who was notified. And again, if you're working in a place where you know that it's putting you at a high risk, the only thing that I could tell you, like really with good conscience, is you may want to go somewhere else. If you try to go talk to the powers that be, admin, express your concerns, and things don't change, I guess only you can make that decision if you want to stay and put your license at risk. My thing is, I know how hard I worked for my license. We all did, right? And I that isn't something that I'm willing to put on the line for somebody who isn't willing to follow good standard of care or standards of practice. Even when that comes to, I've had nurses say before, like in cases that I've sat as a plaintiff expert, if we've had an opportunity to talk or have some communication with the nurses who, or defense, excuse me, like if I'm working with a defense team and some of those nurses have been named. So once in a while they'll say, but my director of nurses told me to do this. I was told to do this.
Right.
And if they're telling you to do things that are outside of your scope and practice or the standard of care, that isn't a place that you want to be. That's all I can say. And I know it's hard to find jobs, start new jobs, whatever, but I guess only you can make that decision if that's somewhere that you really want to stay. For me, I would not stay. I would have a very open conversation with, your director of nurses or whoever it is that take it to that. And if sometimes, if you said, I don't feel comfortable with that, you can actually see internal changes when other nurses know that you walk the tightrope. You do what you're supposed to do. You're one of those just high integrity, honest, you show up, do your work, document it well. Everything is a standard of practice. You can actually raise the climate of integrity within a facility just by starting with one person. But on the flip side of that coin is that you can also end up with circling the drain with a bunch of people that dabble in areas that they shouldn't be, dabbling in.
Mm-hmm. Great. I know just a kind of a point you made about the documentation. I know one thing that I always reiterate when I'm teaching my students is that you can never be too detailed in your documentation. The only thing that will hurt you is when you're not detailed enough.
Right.
So,
and on that note, I will say one of the biggest, everybody loves electronic medical record, right? Because it's like click, click, click. It's a bunch of X's. The problem with that is when we used to do the narrative writing back in the day, people got really creative with their words, and acronyms, and it was hard to read. I've literally had mostly physicians that will say, can you read this note? Because we can't read it. And they're like, I can't even read my own handwriting from 3 years ago. But with electronic medical records, every patient, you could have 7 patients that look exactly the same. Like it's just all the same stuff. And you have to be really, really careful with that if there's little inserts like add a narrative or insert, a comment, addendum at the end, that you're taking advantage of that area, because that's how you really differentiate those patients, so that everybody doesn't look the same on the floor, because otherwise EMR stuff can be just kind of monotonous. And I think nurses get in a habit of they're just click through. And then if you had to show that chart, or that medical record to, when it goes before attorneys, blow it up on a screen for juries to look at, just know that everything that you write in there and say is going to be screened and combed over by somebody like myself on both sides, and then doctors and attorneys. And believe me when I say whatever it is that is in that record will be found by somebody. And you just want to make sure that whatever you put out there, that it absolutely shows your, the best side of you, and that you practiced within the standard of practice and reported to who you should have, and did the things that you were supposed to do for that patient, but that also your record is a very true reflection of how that patient is.
Okay. There is another question that popped up, and it's kind of related. It says, if the WCC is not the nurse providing the care, can the WC ultimately be held liable for the care provided by the primary RN?
So that is a good question. And the answer to that is depending on what the issue is. If a WCC is in and they know that this patient is really malnourished, like maybe they don't have a wound issue, but there's some issue that nurse being in there should have been aware of, or should have known that there was an issue and should have reported it, because you're in there 3 days a week or whatever, right. Then you can be named as somebody. But if you're referring to, a lot of times, like a WCC might see the patient once a week, like at the facility where I practice, we see many of the patients once a week. We take the photos, do measurements, evaluate the care plan, that kind of thing. And then the floor nurses will do the treatment. Like, we're not a treatment nurse, right? We're just a consulting, overseeing, and then we lay it out for what the regular nurse would do. If you know that those dressings aren't being done, or that there's a deterioration in that, like, yeah, by all means, you can still be brought into that, like vicariously, you know, for either not reporting to the director that the wound care wasn't being done right, or the patient wasn't being turned, or the patient was being left in a wet brief, you know, or incontinent or whatever, or wasn't being fed or fluids off it. Like, you can still be brought in. You can basically, you would really have to defend your way out of that one. So if you know that there's issues, now, if it's something that you are completely oblivious to, that some nurse is not doing, it would be, the only thing I could say is that would be like a case by case thing. But you can certainly be brought in on something if you knew or should have known that there was an issue.
Okay. Mm-hmm. We got another one that popped up, and I'm sorry, it's right on the same thing. Okay. We're just going to say, it says, I have been to my DON over dressings not being completed. Should I document this?
Oh, yeah. Yeah. And I know the thing is I mean, I've been there as well. And one of the things that my director of nurses is fantastic about, she's actually told me, like, you know, a thing gets written up, because of course we know that if those dressings aren't getting done, it's frustrating for me if we're not seeing the healing that we should, or we're seeing a deterioration, or I go in a week later and my dressing from last Wednesday is still on there with my date and initials, then I will always I'll look up who was supposed to have changed that dressing, right? I actually go to that nurse. We have what we call a teaching moment. You know, we'll give them that up front, talk to them about that. The director of nurses, the ADON, whoever, is also pulled in and very aware of that. And then if that behavior continues, then they have taken care of things on other ends, on their end. But if you have from a wound care perspective, especially when you're kind of on a consulting end, if you have a really good relationship with your director of nurses or whoever it is that you are to be reporting to, which I would encourage, like, keep those lines of communication open, let them know, because your director of nurses is going to want to see good healing rates as well, right? That's one of the things they track. They track prevalence and incidence and all those kind of things, how fast we're getting them healed. And if you've got, generally speaking, it's usually like a problem nurse, right? Somebody who may be doing that, not just with one, not just with two patients, but you see it kind of consistent. Those things should be written. I will actually write on there, if it's something that consistently happens, my dressing from this was left on. I notified the director of nurses. She, you know, and then it goes on that end, because that way you have to be able to show what happened, what you did, and what was the response for that. That's your accountability on that end. Okay. I know that they don't love seeing that in a medical record, but
from that.
Yeah. Right. But the problem is if you take a photo like last Wednesday and then my same dressing is on and it's like soggy, wet, macerated the following Wednesday, and I go take a picture, it looks worse, and I don't change the dressing treatment, it looks like I did a disservice. We kept the same thing on, that wound was failing. The truth of the matter is that dressing had not been changed according to what it was supposed to have been, and also keeping the physician in the loop, right? Like notifying the physician there was an issue with dressing changes. It's been reported, rectified, and we were going to still stay with this one. And you know what I mean? Like put it through like that.
So another follow-up that just popped up. So, and by the way, Renee, I'm going to get to your question, okay? But yours is really long, and I'm saving it for the end. But Connie asked, as a follow-up, do you recommend documenting in the patient record errors found in patient care?
So I don't use the word errors found in patient care, because I think that's a big red flag. Because if I were looking at that and I saw that, like, you have to be...
alarms go off.
Right. I don't say there was an error. It's basically like red. You might as well highlight it and draw a big heart around it and say, here we go. We're essentially, but what I would say is arrived, dressing was dated, you know, whatever, discussed with the community nurse, discussed with the director of nurses and the physician. We'll continue with it, like, very factual. You don't want to get into, I mean, that speaks for itself, but what it shows is I identified there was an issue. I reported it appropriately. here was the response on that. And what may happen, especially if, for example, maybe it was a pressure injury that just really took a turn for the worst. The person ends up getting osteo and maybe sepsis and dies from that. You can only do so much, on your end with that, but you can say those things without coming right out and saying there was a huge error. I was all upset. Nobody changed the dressing. I was pounding my fist on the counter. Yeah. Right. There's a politically correct way to be able to identify that. The other thing that I would say is that you need to, because like we use a point click system. And so there's one of the questions when we take a photo that says, is there a dressing like on? Is it even on? Is it saturated, dry, whatever? If it's not on, I can identify it there. Like no dressing on, or it was saturated because it's been on and then it might even say when was the last dressing change, and I can identify that in there. I would never go and say nurse so-and-so didn't change it. Like, Nurse Laura did not change that on Thursday, and then Nurse Jennifer didn't change it on Saturday, and I went and did this and that. Like, you don't have to get into all of that, but you do. It's always good to say this is what had happened. The physician was notified. We're, moving forward, going to keep it, or we're going to adjust it. One of the things that I will tell you, if we have a consistent problem with that, the other wound nurse that I work with, sometimes we will adjust those dressings. We'll put them on our list for a couple of weeks. And that is our response to that. So we'll say, no matter what, the wound nurse is going to do this dressing. If it's Monday, Wednesday, Friday, they're on our schedule, Monday, Wednesday, Friday, right. And it does give a little bit more work for us. But then that way we can say we took it back. We got that thing healing in a way. We started seeing a good response. And then we kind of tapered it back to once a week with the floor nurses doing the other stuff. So you just have to be able to show, again, if you identified a problem, who was notified? What was the response to that? Was it an appropriate response to that?
Makes sense.
Right. Yeah. And I think I see that too. When PT, when you're multidisciplinary. So say PT's doing the debridement, they're doing the E-stim, and then maybe they're not there, or maybe they're only treating 3 days a week, and nursing is supposed to, and we have to be really good at communicating what's going on with all disciplines and who's responsible for what on what days. And that's where I see sometimes that communication could be better.
Well, and even, for example, we have a patient that physical therapy was originally set up. I spoke with physical therapy myself and said, I want them up for lunch because I feel like that was a good time. They have a big pressure injury on their coccyx. So, right. 30 to 45 minutes up in their chair, but that's a good time to get them up, let them eat while they're up. And then, but when I went in today, the patient was saying, I said, when was the last time you were up? Did you get up today? And he said, no. And they said, I don't think he's been up for a week. Well, I was like, hold the phone. What happened to our plan of treatment? And when I got talking to the patient, he said, well, I haven't wanted to get up. And so he and I had a big discussion about the reasons why we still want him up for a little bit, like health-wise. And then I reached out to physical therapy and said, if there is an issue with this patient not following what we're trying to put out as a plan of treatment, please notify me. So in my records, it shows, I discussed with the patient at length. The physician was notified that we've had a little, hiccup in the plan of treatment. I talked to the patient's wife is notified, the community nurse, the house supervisor, and we're going to go ahead and try to get them up. But identifying without coming right out, the new word we like is non-adherent versus non-compliant, right? But keeping the patient a part of that and holding them accountable as well, because we do know that I think sometimes from a wound care perspective, because they take a long time to heal and it takes a lot of compliance, adherence. And if there's issues with that, always identifying every single time there's an issue with non-adherence. We were told, like when I got into nursing, we were told, don't write anything negative in the chart. They don't want to see anything negative. Then you don't have anything to fall back on if that patient is refusing to take their supplements and they're not eating protein and they're eating tater tots for every meal and candy, and they don't turn and reposition, and they are refusing to have their brief changed, refusing to get up when they should. And so all of those things are things that you need to be identifying that there's an issue, and explaining to the patient. We kind of talked a little bit about this started, but a big word that is especially in long-term care, skilled care, is a risk versus benefits form, or having a form in there that identifies if they're non-adherent to the plan of treatment, holding them accountable, saying, if you don't do these things, here's what can happen. And Denise, when you talked about using a multidisciplinary approach, of course, this would be bringing in your social worker,
Right.
The physical therapist, all of the ancillary disciplines, the physician, if there's a power of attorney involved, the patient, that everybody's on the same page, everybody's on the same line, there's no question with that. And then the patient understanding that if they don't follow these things, this wound could get worse, progress worse. They could end up with an infection and potentially die. Like those things have to be identified. But it is a constant turnover of documentation that shows a very true and clear picture about the patient and their wound. And then what we are doing for them. Are those things working? If they are continuing, if they aren't working, what are we doing to fix that? And are the appropriate parties that be, the appropriately ancillary disciplines that are in there, is everybody staying on the same page with that?
Good. Excellent.
Okay, Bill. I think is there another question that popped up? I think I saw.
No, I'm going to save Renee's for the end. So.
Okay. All right. So I have a question then, Tracy. If a patient is wishing, their wishes are to go against what your facility policy is, then how do you address that? Kind of a resident right versus facility policy.
Right. And honestly, it kind of depends. Every one of those will be a case-by-case basis. So if we have a resident who said something as significant as like, I choose to smoke, and our facility is 100% smoke-free, vape-free, right, then they will be asked to leave. That is non-negotiable, right? Because that's like a safety risk for other residents and patients and that kind of thing. So long as it isn't involving the safety of the staff and other residents. If it's something that pertains strictly to them, like we have a resident that said, I absolutely don't want to be woke up, during the night to be turned or repositioned. I don't want to be turned on my side. I don't want that certain cushion in my wheelchair. I don't want to go work with physical therapy, whatever that is, but it's very, just personal to them and their care and treatment. Then obviously a risk versus benefits, having those IDT meetings or those case conferences, identifying it, and then making sure that the patient, well, if they have an understanding or their power of attorney signs off saying, we understand that very specifically that by not doing these things, this wound can worsen, or we can see a decline in these things. And then using that as a continual, when you have that meeting of somebody who is non-adherent or non-compliant to whatever it is that you're trying to do for them, that is a continual process of your documentation from there out, right? So every time I go in, I made as a reminder, we talked about, we're not seeing any progress in this wound. In fact, it's getting worse. So we reviewed again, the risk versus benefits. I hash that thing over and over and over and over, because then if an attorney or a nurse expert were to look at it, the thing that people don't understand, it's not usually the patient who sues, right? It's the family. Yeah, that something happens to the patient, and then you've got and sometimes it's distant family, like a great niece or a great nephew or a great grandchild. It's like the weirdest. These people come out of the woodwork, and they're like, "Oh my gosh, they harmed, Nana. She was in the nursing home, and she ended up dead, and she was 99, and we don't like how they treated her," and they're going to want to push for a case. But if somebody sent me a case to review and I could see that consistently, this little patient was like refusal, and the staff were constantly trying to be like, here's what we'd recommend, this is what we'd want to do, but they still have a patient right to refuse care and treatment, then those things, that's a case that I would hand back to the attorney and say, I don't think this is a case. It's not one that I would push forward through, because there was a lot of patient refusal, patient non-adherence. I just don't think you can win that kind of a case, in a court of law, regardless of whatever the outcome was. If there's a large amount of non-adherence, non-compliance, refusal, and those IDT meetings and those risk versus benefit forms are in there, you cover yourself. And so it wouldn't even be something that you probably wouldn't even ever be notified, that there was an issue.
I think that's a great point, in that whenever you're charting, whenever you're writing or typing, as it is now, is to be thinking about if this went and an expert looked at it, what do I need to include so this is not a slam dunk case?
Right.
What are those details that are going to protect us?
Well, and a lot of times,
and hopefully prevent it from even going, to court.
And that's it right there. Because if a nurse is looking at it and it looks like that facility did everything they could have done, and yet there was maybe still an adverse outcome, we know that those things happen, right? I think I'll just bring this up, one of the big litigated terms that a lot of attorneys like to use is an unavoidable pressure injury, right? They think any injury is unavoidable. Well, we do know the way that when things go to court, the pressure injury development is often a sign of neglect. That's how it's termed in a deposition court of law, whether it was neglect for being turned, repositioned, dietary, changing a brief, keeping them clean, dry, whatever it is. Now, that being said, we do know there are, a Kennedy ulcer that can develop end stage, but an unavoidable ulcer can truly only be termed that, even if a physician says this is an unavoidable ulcer. The problem is the national pressure. It's not a problem. It's actually great that they actually put a position out on it that it can be termed that if you identify the patient or resident as a high risk before they even developed. Like, we know they're a high risk. If they come in with a pressure injury, they're a high risk, right? They already came in with one. Regardless of what those little numbers in your graph show, they're a high risk. So you identify them as one. Number two, what interventions were you doing to prevent a development of that? Like, did you have them on a specialty mattress straight up? Were you addressing their nutritional? Were you changing? Were they getting bathed? Were they, were you doing all the things that we know as wound care providers that we should be doing? Three, that was documented. And then even if after all those things were being done, they developed this pressure injury, that is the true sense, the true term of an unavoidable pressure injury. But if you don't have, you cannot just say it was unavoidable because they were old and they had cancer and they didn't turn. You can say it's unavoidable if you can show that we did all the things in place, and in spite of doing all those things right, they developed this. That is how that works. And people, you can pull that paper off the National Pressure Injury Panel. You can pull that paper and look at that. That's one of the things that you set yourself up for more failure if you're right away throwing that term out. It's unavoidable. This because they were old. They had fair skin, or whatever it is. You cannot use that term if you don't set the base for it to say, we identified and we did this, and then they developed it in spite of that, not when it goes to a court situation. So being aware of that's probably one of the biggest topics that we get, that would get argued with an attorney from a nurse expert.
Cool. Well, thanks. That was awesome. You've already answered. You kind of jumped ahead, got a bunch of our questions out of the way, but we're getting some good ones coming in. So we're going to stick with the audience right now.
Okay.
There you go.
This will be a real easy one here. I mean, it should be almost basically yes or no. Does the plan of care have to be documented in the note and in the order?
In the order. So, and that would be different than a care plan. I want to identify that we know, especially nurses, we need to have the care plan needs to be reflective about what is in your orders, right? What we're doing, and your care plan is like a roadmap, how to get from, we have this, we want to get from point A to point B. I always say if you were going to drive to New York from Las Vegas, you would use a map. You would say, I'm going to stop for gas here, I'm going to sleep here, I'm going to whatever, like you would use a map to get there. I wouldn't just get in my car and say, I'm going to drive east and hope that I get there, right? So that's kind of what a care plan is. But yes, to that point, there needs to be an overlap of that documentation to show it is a continual, like, smooth process. So I always say I document a lot, like what I'm thinking about, and if we don't see the response in this that we expect to see, then we will evaluate by the next, wound evaluation, we'll certainly discuss with the physician about changing it up to potentially this. Like, I think out loud a lot in my documentation to show that there's an ongoing continual process, or we're seeing an improvement, they're eating, da 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 da. One of the biggest things when it comes to plan of care plans is that making sure those are patient specific and that they have reasonable goals, right? And that means that you're not saying we expect to see this wound healed in 90 days, right? Most long-term skill, they have a generic care plan that comes out, and it will say most everything will be like, they won't fall for 90 days, the wound will be healed in 90 days, and that's basically the day they were admitted and a 90-day till the next follow-up is. The truth of the matter is your wound care planning should say, I expect to see 25% wound healing in the next 14 days. You have to give a specific. And then if you're not seeing that, what are we doing about that to evaluate that and fix that? That's that continual ongoing process.
Cool. All right, next one up. Should you then should you have more than one person validate the information regarding education in the chart? For example, like the physician as well as the WCC or the nurse or the therapist. Should there be more than one person charting that education was provided to kind of validate it? I'm assuming that's kind of where we're going with that question.
Yeah, I mean, in a perfect world, that would be great, right? It's not always a perfect world, but really you can only be accountable for what you are teaching. Now, I know even if I have a resident that's in a sugar splint or a surgical walking boot, which technically falls into the physical therapy end, right? Because that's like one of the things they deal with. But if I need to make sure that patient is supposed to be non-weight bearing or should have their surgical shoe on, I will always document that as well. So a lot of times you will see an overlap of that kind of teaching. Dietary may be in talking about the nutrition that's required to help those wounds to heal. And then I myself would also be saying, we want to make sure that your high protein diet and that, you know what I mean? Anything that you teach and talk about should be in there, but you can only be accountable to you. I've never told another discipline, I need you to chart on this or to make sure you're teaching this. I think that I'd like to think that, those disciplines are going to reference that education and training. And I think a lot of the new EMRs, they highlight those areas specifically. Like you'll always see an educational component so that should be put in. But whatever I teach, whether it's dietary, how to do the dressing change, infection control, something with, maybe a surgical shoe or whatever it is, I write that in there. And so there may be an overlap, and that would be great because that just reinforces that's been taught.
Cool. All right, another one. How much does the issue of dementia and patient choice affect negligence or malpractice decisions?
So again, another great question. And what we always go back to there, if those people are unable to make safe, educated decisions for themselves, then their power of attorney or whoever is assigned to them, their guardian, is the one that is responsible to hear the teaching and education to make those choices, right? We do know that we do have this can be one of the most difficult groups to work with because they're very childlike. They may refuse things, refuse the dressing, have a lot of refusals. The offset of that is you write, the patient, the resident refused this, here's what we did, but here's who we notified. Their family was notified and the family said, please don't bother them. You know what I mean? Like we don't, it's obviously upsetting grandma, grandpa, mom or dad or whoever it is, or they may tell you, go ahead and do X, Y, and Z. But having the person who's accountable for them, that person has to be notified, has to be a part of that, in the loop all the time. So there's times I've had to call some family members 3 times a week. Every time I'm in to see that patient, I call them every single time, just to keep them in the loop. But people that you notify and have that good kind of rapport with, regardless of the outcome, they're going to know that you were doing the very best they can. They're not usually oblivious as to how the extent of I sometimes like the aggression or the dementia, Alzheimer's, however extensive that is, they're not oblivious as to what's going on with them. They just need to be kept in the loop and in the know as to, maybe the struggles and difficulties that you're having with them. Sometimes they have to come, like this whole COVID thing has been very hard because most of these facilities are closed. There's not outside people able to come in. So it poses a whole different kind of, we don't have a family member that could come there during a time of a difficult dressing change or something. So we just have to get resourceful. But like I said, just keeping that, every one of those people will have an assigned power of attorney or guardian, and you have to reference them when it comes to things, especially if it was maybe cares that aren't being done or something that, if they're refusing to have something done, you just kind of have to make sure that their power of attorney is in the know.
Yeah.
That's kind of within my wheelhouse as well, because I've specialized in dementia care. And so there's testing that can be done, and then that would let us know, can this person be taught, or are they past that? What other interventions can we do? And there's a lot of therapeutic interventions that can be addressed and used as interventions with those dementia patients. I've painted stop signs on bandages before to remind them not to take it off. And then the more you document that multiple interventions were attempted, then that, I think, also strengthens that case of how well you were trying to take care of them.
Right, 100%. And that's, I think a lot of times when there is a family or somebody that is upset with whatever's going on, it's because they weren't notified. That's one of the biggest issues. On that note, like these COVID cases, when they were first coming out, the thing I kept hearing on the news was families were not aware that COVID was even in that facility where their loved one was. They just want to be notified. They just want to be told what's going on. Keep us in the know. Let us make an educated decision based on what information that you're telling us. So it's really, really important. It is one of the key things you're required, especially in long-term care and skilled care, to notify their power of attorney or spouse or whoever it is. And you are required anytime there's a change in their condition or a new medication, so just be really, really aware of that.
Okay. There is one that came up, and maybe you just addressed it, and I don't know if you add any more. It says, how does COVID isolation and increased risk, how should it be documented? Is there anything else you want to add to what you just said, or is that sufficient?
So I do know that there are regulatory requirements that are put out now for like long-term care and stuff. You need to be referencing like what CMS guidelines, because those are changing almost every single day. I can tell you we have a crew app, and every day it's like, you need to write this, you need to write that. But the facilities usually put a thing out and say, every single patient's going to be checked this way. We're going to be doing this. You have to note these every 2 hours, symptoms, whatever it is. Always go to the higher source, that is the credentialing agency or the regulatory agency. It's not something that you can make up on your own, because these kind of things, especially with the COVID, it's very highly, like, everything's put out there. Everything's put out there, what you need to be doing, what kind of documentation you need to be showing to support that. So always go to the powers that be that would like regulate that. I always say, don't take a vote. Don't stand together as 4 nurses and say, what do we think would be the best? Like voting in that kind of a place is not, even if they said all 3 of us nurses on the floor felt best about this, reference whatever it is that, where that guideline would come from.
Cool. Now this one's a little more patient specific, so I don't know what, or how much you want to handle. It says, what do you do when a patient has calciphylaxis on their backside, so I'm assuming the buttock area, with severe pain, and their vital signs are 90/50, and they cannot get their pain shot because it will make their blood pressure drop even more? Would you document that? And it happened 2 or more days after, and finally they coded, and then went on a vent and a drip. How would you document that defensively?
Yeah, that is one of those that, I'm going to kind of like plead the fifth on that, because it's like, that's a lot of information to share. The one thing that I'll say is pain management is a big issue in regulatory. The thing about pain management, you're not just stuck with one shot, right? There are other avenues that you can, there's topicals, there's like oral medications. So if what you're doing isn't working, or if every time you give them a pain shot, it bottoms out their blood pressure and they're having other issues, you need to be speaking to the physician and asking for something else. Because I've done wound care for years and years, and there's other I would evaluate different interventions is all I'm saying. And being very aware that, your documentation, reflects that. So it just sounds like that maybe there needed to be a case conference. More heads are better than one. It's not just your responsibility to figure out what do we do when the blood pressure drops. There's, the director of nurses aid and call in the pharmacist. Ask the pharmacist is a great resource to have in there. Like, what are other avenues and options that we have? I do know those calciphylaxis in those ulcers can be very, very tender, very sore. But even doing interventions like keeping them off it, right? First and foremost, like keeping pressure off that. There's a lot of things that you could do that would take probably an hour to talk about just on that end. But my thing is to make sure that you have a team meeting, have an IDT with all of your disciplines, and then talking to the patient and explain to them, here's what we need to do. If the patient was so critical that giving them like one shot of a pain medication was going to bottom them out, I kind of have a feeling just off the top of my head, they didn't die just from a pain medication from that, unless they had like, an allergy or something. I think there was probably more to this whole component than just that. Yeah. So utilize your IDT team.
Yeah. I was going to say a lot of that will get punted to therapy, and we would think about topical applications, TENS units. There's a lot of interventions that we can do for pain control in those situations where they can't tolerate medicine.
Yeah.
Right.
Good. All right, next question, and this is coming from the home care setting. Can there be a legal issue for the RN if he or she only assesses a wound every 30 days and the LVN or LPN is the one providing the wound care and assessments of the wound?
So again, and I'm very familiar with this, I did home care for years. A lot of RNs are asked to oversee, right? Supervise your LPN or LVN. And so, there is, yes, for sure. If you are supervising, because that's basically what you go in 30 days, you're doing a supervisory visit, usually of the CNA if there's a CNA and the LVN, you are the supervising RN. So that absolutely does put you, if you know that nurse isn't following good practice, or that the wound is deteriorating, you're just not seeing the healing that you should be doing, then that's when you, of course, like, what interventions are you doing different for that? Part of that would be having a case conference with the LVN, discussing that with the director of nurses or ADON, again, pulling in those, going to fixing the root of the problem. But absolutely, if you're the supervising nurse over that, you can have issues with that. Now, if you're rolling out a treatment plan and you're saying this is what's supposed to be done, if that nurse is not doing according to whatever the treatment plan is, they're kind of when those dabblers are just doing, makeshift whatever, and you get in there in 30 days and you know, or should have known that this was happening, you have a responsibility to make sure that nurse probably is not seeing your patient, right? Like I have had a few LPNs over the years that I was like, I'm not going to put my license on the line for this nurse, because every time I go in, there's an issue. Right. And it sounds really difficult to say. Don't get me wrong, I'm very loyal to my nursing profession, but it's your license on the line ultimately,
Makes total sense.
Yeah.
Total sense. I don't have any other questions. We've got pretty much wrapped up. Denise, do you have anything you want to add as a follow-up question or final wrap-up question here for Tracy?
I do not. I think it's been great information, Tracy. Thank you so much.
Oh, thank you. I appreciate you guys' time. It went by so fast. Thank you, everyone, for the comments.
I mean, literally, we've been doing this for an hour, and it's just like, boom, where did all the time go?
It is one of those things. I will tell you, protect yourself. Make sure you're practicing the standard of care. Make sure you're writing what you do. Take credit for what you do. And I think one of the things I saw early on was like having a good demeanor with your patients can go a long way. Because you're nice to somebody, it doesn't mean that you won't ever be named in a lawsuit, but it can certainly go a long, long way. We can all be nice to somebody, but if there's an accident, you kill somebody, it doesn't matter how nice you are, there may still be a lawsuit identified at some point,
Exactly.
So anyway, just do what you're taught to do way back when you went to school. It will protect you. It will keep you safe. Be smart. Don't be afraid to go to your director of nurses, notify the physician, and keep the patient and the family in the loop all the time. Keep those lines of communication open. I think those are probably some of the best tips that I could give you for protecting yourself.
Excellent. Well, thank you, Tracy. We really appreciate your time tonight. I know the audience does, and obviously our viewers that will watch the recording, after this will hopefully as well benefit from all the great information you shared. So thank you again.
That's great. Thank
you.
you.
Seeing you.
Thanks,
We'll
you guys.
see you again. Good.
Okay. Thank you.
All right, everybody. We are wrapping up for this evening. However, just a little quick heads up. Next week, the topic is going to be your questions. So we are asking everybody if you have any questions that you would like answered. Denise and I, being it's the week leading up to the holiday, are just going to do a session where we are going to take your questions and just kind of rapid fire go back and forth through those questions. So if you would submit them, you can post them on the Wound Care Gurus Facebook page. You can email them to customersupport@woundcaregurus.com. But anyways, if you want to submit your questions to us, we certainly will do our best to answer as many as we can next week. And Denise, anything you want to finally say as we wrap up here?
No, just been a fantastic week. We appreciate all of the audience participation, that we know that we are giving you the content that you want. So thanks to all of you that support us, and fantastic job with Tracy tonight.
All right, everybody. Until next time, have a great week and heal on.
God bless. Thank you all.